slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough.
Thanks for being here. We're here today to cover the first episode of Ophthalmology on internal medicine boards, and we're going to be using AI to create board questions based on the educational objectives that are commonly tested on the boards. And these are objectives that you can find also on board resources such as MK-SAP and UWorld. But I've created certain instructions to create questions that tackle the specific questions that they're going to be asking on the boards. And I have all of the notes from each of these sessions on my Patreon channel. All of the subtopics of internal medicine are into a playlist, and you can play the playlist, listen to them when you're going to work, and we're going to try to be fast and effective. You can increase the speed and listen, and hopefully you learn something. I really appreciate if you guys subscribe, leave a comment, like, dislike even. Just let me know what you think about these episodes and if they're useful to you. So we're gonna go ahead and get started. All right. So we have a 27-year-old man. He presents with acute onset of the left eye pain after getting dust in his eyes while working in his backyard. He reports a gritty sensation, tearing, and photophobia. He denies any vision changes or trauma with a sharp object. On exam, visual acuity is normal, pupils are equal and reactive, and there's no discharge. Fluorescein staining reveals a linear abrasion on the corneal surface and no foreign body is visualized. The patient wears contact lenses occasionally but was not wearing them at the time of this incident. So which of the following is the most appropriate initial management? So go ahead and pause the video right here, pick your answer, and then we're going to go through the options together. All right. So I hope you know that the educational objective here is going to be about corneal abrasion and the treatment of corneal abrasion. And a lot of people actually think that eye patching is a thing with corneal abrasion, and that's absolutely incorrect. And that's why we need to really know when we do something about corneal abrasion and what is the first line. Okay, so pathophysiology is that these abrasions disrupt the epithelial surface of the cornea. They expose the underlying stroma, and this leads to pain, photophobia, foreign body, this gritty sensation. If it's untreated, some of these abrasions can become complicated by superinfection, and those are usually bacteria, especially importantly in people who wear contact lenses and those with larger abrasions. These are at high risk of infections and complications. So the question, when you look at it, there's some key clues in there. There's eye pain and foreign body sensation. There's a fluorescein testing that shows the linear abrasion. There's normal vision, no contact lens during the incident, so it's important because that will change your first line option. And no white spots or infiltrates, no irregular pupils, important, no red flags, right, to basically telling you, hey, I need to send this patient to ophthalmology right away. So option A was topical corticosteroids. These are contraindicated, very important to know, as they impair the healing and raise infection risks. Okay, so option B was oral antibiotics, which be also incorrect. We use those for orbital cellulitis or deeper kind of infection, not just the epithelial surface, right? Topical erythromycin is actually the correct answer, and this is the first line for uncomplicated traumatic abrasions without contact lens use. Eye patch placement actually is not recommended because it will cause delayed healing and also infection risk will increase. Urgent ophthalmology referral is reserved for ulcers, infiltrates, vision loss, irregular pupils, and the ones that actually don't basically heal, the abrasions that don't self-heal within the first 24-48 hours. So assess for the red flags, identify the cause, and if there's traumatic and no red flags, you can start this. And also remember, you don't really need a follow-up to ophthalmology for smaller abrasions that are improving within the first 24-48 hours. So if there's less than 3 millimeters, are pretty small, and this improves over the next day or two, you don't really need to see the ophthalmologist. If it doesn't and it's slow or something, just go ahead and refer to ophthalmology. If contact lens use, remember your antibiotic needs to have anti-pseudomonal coverage, so you need to use a fluoroquinolone. Okay. The buzzwords here and on the boards, they're not going to give you all of the findings. Again, these questions are there to give you all of the things that the boards can have, but boards usually mixes up with other things from other presentations and basically gives a lot more for one condition. So a lot more findings and signs for one specific condition, but there will be few things that could also correlate to other conditions to throw you off. But if you know all of the things for one, you can pick, okay, there's 4 out of 5 things or 3 out of 5 things that presents, and with this specific type of presentation, and you will be able to find out first of all what the diagnosis is, and then also know what the treatment is going to be. Okay, so this kind of goes through the guidelines, and there's also some UWorld guidance and the American guidelines for ophthalmology. They do use topical ointment and not drops. Remember that for traumatic abrasions. Contact lens users require anti-pseudomonal coverage, and the eye patching is not recommended. Okay. The takeaway point would be for small, uncomplicated, traumatic corneal abrasions with no red flags, topical erythromycin ointment. Okay, so it keeps repeating and repeating just to make sure you do not miss these questions. The goal is to this educational objective after this video is going to be solidified in your memory. That's the goal, and you can watch and rewatch these episodes. Okay, if you're enjoying these sessions, please drop a thumbs up, a like, subscribe. Let me know what you think. I will be posting every day, okay, on all of these high yield and more difficult questions that sometimes, as internal medicine doctors, we may miss. So 69-year-old woman presents to clinic with complaints of recent difficulty reading street signs and watching television. With eye problems, always notice the age as well. She reports that she actually had to reduce the strength of her reading glasses to see better up close. She denies eye pain, discharge, or redness. Her last dilated exam was 6 months ago, and it was normal. Her medical history includes type 2 diabetes and hypertension. Which of the following is the most likely cause of this patient's visual changes? Okay, so go ahead and pause the video right here. Pick your answer. We're going to go through each of the options together. Okay. All right. So the educational objective that this is trying to test you is really the diagnosis. And there's a very important finding with nuclear sclerotic cataract or just nuclear cataract. Okay. So nuclear cataracts are age-related opacifications of the central lens nucleus. Okay. And it's due to oxidative damage over time. This leads to thickening of the lens, which causes a myopic shift, basically reduced distance vision with improved near vision. So this is a very, very characteristic finding. You need to remember reduced distance vision and improved near vision, which may precede visible lens clouding. Okay, so you may not really see that lens clouding and cataract eyes that you see in practice because the first sign that they're gonna start to notice is the myopic shift without the clouding. Okay, so key clues: this is an older adult. We have recent myopic shift, better near vision, worse distance vision, normal dilated exam. There is a diabetes history here, which is a risk factor. Presbyopia, this is causes loss of near vision and not an improvement. And this is again seen in aging 40s, 50s. It starts to happen. Macular degeneration again affects the central vision and affects the reading, facial recognition. Typically presents with distortion or scotomas, not a myopic shift. Option C is open angle glaucoma. This would be a painless peripheral vision loss. Okay, just remember this. Not a central acuity or refractive change. It's detected with IOP plus visual field testing. And option D was the correct option, which is the classic myopic shift hallmark, early sign, often preceding the visible opacity. Diabetic retinopathy usually presents with retinal hemorrhages, microaneurysms, vision loss on fundoscopy, and not a refractive change alone. And so when you go through the algorithm, see if there's refractive changes in elderly. Think about there's a myopic change or shift, any acute findings. If not, probably early nuclear cataract, presence of risk factors, age, diabetes, diagnosis, nuclear cataract, refer when vision affects daily function. And again, these are kind of like pattern recognition style. These are my instructions to give these. Old patient, normal eye exam 6 months ago, presents with myopic shift. Think about this subclinical cataract. Cataracts often precede visible changes on eye exam, and they will always try to give you something that you cannot see on visibly. Like they're not going to tell you, hey, you look at it and there's corneal clouding, right? They don't want to give the diagnosis away easily, so they may do this to you. So going through the guidelines, cataract surgery is indicated when the cataract impairs daily activities despite correction with glasses. Nuclear sclerosis is most common age-related cataract and typically progresses slowly and asymmetrically. Myopic shift is a classic early presentation. So kind of like more sudden, right? About 6 months. Improvement in near vision in an elderly patient with new distance blur suggests of nuclear cataract induced myopic shift, and everything prior exam will be normal. Okay, so if you're enjoying the video up now, don't forget to drop a like, comment, subscribe, and let's move on to our third and last question of the day. We have a 74-year-old man who presents with progressive difficulty reading and recognizing faces over the past year. Okay, so he reports trouble seeing while driving at night and describes a gradual worsening of central vision in both eyes. He has a 40-pack smoking history and a family history of vision problems. Visual acuity is reduced bilaterally. The fundoscopic exam reveals yellowish deposits and pigment changes in the macula. Okay, so this is very important characteristic. Which of the following is the most appropriate next step in the management? So go ahead and pause the video right here, pick your answer. We're going to go through the options together. All right, so this is also a very important educational objective about dry macular degeneration. So the treatment is actually here going to be initiating daily antioxidant vitamin and zinc supplementation. And if there was an option, it would be for him to stop smoking. Okay, very, very important. So dry age-related macular degeneration, or AMD, results from chronic oxidative damage to the retinal pigment epithelium and accumulation of drusen between the retina and the choroid that disrupts the photoreceptor function, leading to gradual central vision loss. Okay, so very important to know the pathophysiology behind how this happens. Age greater than 70, gradual central vision loss that is bilateral, smoking history, a fundus that shows drusen deposits plus pigment changes. You need to think about it. And the options would be the antioxidant and zinc in this case, recommended by AREDS2 trial for intermediate or advanced dry AMD. It's shown to slow the progression and protect the good eye. Okay, so option B is topical beta blocker. This would be for open angle glaucoma, not AMD. High dose corticosteroids, again, no role in dry AMD. Risks outweighs the benefit. Option D, urgent laser photocoagulation reserved for wet AMD and not dry subtype. Ocular lubrication drops for dry eye syndrome and affects no effect on macular degeneration. So the algorithm for clinical decision making is to see vision loss in an elderly. Is it central? Is it peripheral? If it's central, gradual, and there's drusen deposits, think about dry AMD. Make sure to tell them to stop smoking. Take antioxidant plus zinc to prevent further damage. No laser or injection unless there is wet AMD. Okay, so pattern recognition was thinking about this bilateral central vision loss, the drusen and pigment changes on the fundus, and the treatment and the supplements based on the AREDS2 And when you go to that and look at that, some of the things that on that trial were antioxidants such as vitamin C, vitamin E, zinc, copper, lutein, and this amazing zeaxanthin or something like that. Preventive would be to stop smoking, get a routine eye exam. And for wet AMD, remember we can use intravitreal anti-VEGF or VEGF, vascular endothelial growth factor, such as bevacizumab to treat. And for patients with dry AMD, the goal is to slow the progression and preserve vision using daily antioxidant vitamin plus zinc and encouraging smoking cessation. So thank you guys for staying till the end of the video. Thank you for listening in. I hope you guys learned something. The whole point of this is to show you how AI can really help if you give it proper instructions and know how to augment your studying. It's a great tool actually to augment your studying, to your work. And at the end, why should I use AI? I mean, I'll just tell you, this is basically not a paid promotion. I just create these pictures using one of these apps, and you don't even need to use a specific one. But I think it's amazing. Like, if you have a creative mind, if you imagine things about yourself and your future, and I mean, it's just so many things you could do. I thought these pictures were pretty funny. So I hope you guys enjoyed. Don't forget to drop a like, subscribe. I'll see you on the next one.